Start. Oh, I'm still perfect. Welcome everyone. Brad Richards, Chief Medical Officer, Department of Social Services. For those who don't know me, I'm just going to welcome you to our second June provider maternity bundle forum. Just as a FYI, for those who may have joined our most recent one, this will basically be a repeat, but if there's new questions or other things that come up, we just wanted to make sure that we offered 2 times for busy providers, especially since we're doing it during the day. So just why we're doing it, again, the other one is recorded. This one's recorded as well. We'll plan on posting it on our DSS website, but just want to welcome all of you. We really appreciate the engagement to date and are looking forward to continuing the work as we get ready for the launch and after the launch of the maternity bundle. So thanks for being here. Just some ground rules. So again, this is recorded. We'll be posting it to the DSS YouTube channel. Materials are available on our website. Please make sure you're muted. We'll limit the chat function of the Zoom just for technical audio issues, and then use the Q&A to post questions. Questions are you're also welcome to raise your hand for if you'd like to speak, and we welcome either way for questions to come out. With that, I think we'll move on to our agenda, which will be a program status update, talk about historic dry run reports, and then do case rate updates. We can jump right in. So this is kind of where we are, and we're still planning and on track to launch September 1 of 2024, pending some federal approval, though there is an open discussion about whether, as long as we've been in discussion with CMS for some time, as long as we're really close, even if we haven't gotten final approval, we may decide to launch the program. So, but the plan is not to move this date. We're planning on launching in September 1st. So the things we've recently done, we've finished actuarial modeling and program testing. We've sent out draft case rates, historic performance reports, and we have video guides and FAQs. We're currently working on finalizing the SPA approval, the state plan amendment approval with CMS. We have active conversation ongoing with them, and then program readiness as well. So just finalizing key details, and then upcoming, there'll be provider bulletins, payment policies, processes, the final performance year case rates. So we sent out draft case rates. We want to make sure people understood those, where they came from. We're planning on sending out final case rates out for the go live on August 1st, and then also performance year provider reports in the future as well. And I think we can go to the next slide. Just note that on the slides here there is links, so you can also just search for the DSS maternity bundle YouTube, but you are welcome to click on the links here. We'll make sure the materials are attached. But it's easy. You could just search for it. See, Mark, your hand's up. Oh, you're on mute.
Thank you, and sorry that I was on mute. So, the state, the state plan amendment is a current priority. What do the feds need in order to have an approvable state plan? Do they need final case rates? Are those or is it just a methodology that they're?
As of now, methodology, we share draft case rates with them, and we've had some conversations. So they haven't requested the final case rates, as long as we'll be, I think, sharing them out publicly once finalized.
All right. And so is that approval, do you think, imminent, or what are the issues that still need to be?
Wish I could say definitively. There's been probably slower. We've actually engaged with them for over a year, but I know they've internally been had some challenges just in terms of their workforce and ability to engage with us. So, but we have had active engagement. We had a meeting either the week before, 2 weeks ago, and we've continued to get feedback in terms of updating the SPA language, which we've been doing. So I think we're pretty close to finalizing that language. Though, we're, as you know very well, Mark, I think there's possibly anything could change at the last minute. So I think it's relatively imminent. I think we've been saying that for some time since we've been engaging with them, but we anticipate, given where we are in the process and our engagement with them to date, that we will get approval probably before September 1, but we're just readying ourselves to, we may need to launch as long as we are possibly launch if we don't.
Okay. Thank you very much for that.
Of course, no problem. So the performance reports, and this is where I'm going to pass it over to Grace from the Mercer team to kind of walk us through some of the historic performance reports.
Yep, thanks, Dr. Richards. Yeah, so I will walk through just some high level goals for distributing the historic performance reports, what's included there, what are the key takeaways from those reports that have been distributed, and just really to walk you all through that. So as mentioned on this slide, this report, we generated it to achieve a couple goals. One is to understand the reconciliation process, as the report outlines all the key components to get to the final incentive payments, and also just to kind of illustrate what historically the provider-specific data have looked like. Obviously, when the program go live, things will look possibly different, but at least, just to give everyone an understanding of, what the results might look like based on the historical fee-for-service payment structure. So this historic performance report includes, like I said, a lot of very important components for the reconciliation. So we did look at we indicated the target price we used like the historic period of time for dry run. That is the delivery happened from 10/1/2020 to 9/30/2021. So we use that year of delivery to set the target price. And then for the dry run performance year, where we actually look at the actual episode cost to compare against the target price, those are based on deliveries from 10/1/2021 to 9/30/2022. So just like how things will work for year one reconciliation, we'll use the year prior's experience to set target price, and then use the actual performance year's experience to calculate the actual episode cost, comparing those, and then come up with the share saving amount. In the historic report, we also outline some of the methodology details, some caveats, just things like that for your acknowledgement. And then in the future, when we have year one, obviously things will be slightly different, but at least you can take a look at what will be included and the factors will be taken into account. Next slide, please. So how does the reconciliation work? I do believe this is also information that has been included on the historic performance report. But basically, as I mentioned, the first step is we're using the delivery period 1 to the performance year to set up the target price. Just a refresher. The target price does account for, the provider-specific member risk pool, like their member acuities. We also reprice the inpatient hospital to make sure it is we take away the hospital-specific factors. So we use a standardized price by DRG, by severity level, to sort of reprice those inpatient claims. We do the same step with actual costs. So all those hospital-specific, pricing differences will be taken away from this calculation. So, and also, outliers are removed from the when we set the target price, which means any episode costs above 99th percentile and under 5th percentile are capped at 99th percentile for episode costs, and also the ones under 5th percentile brought up to the 5th percentile episode cost. So all those sort of adjustments are made when we set up the target price. And obviously, based actual cost, we do, as I mentioned, reprice those inpatient claims to make sure hospital factors are taken away from it. So comparing these two costs, we get to the net savings by provider. And then the net savings then will be shared 50-50 with between the state and the provider. And then so the provider share, which is 50% of the net savings, will be used to combine with the final quality score, which indicates the percentage of shared saving each provider will be awarded. And then that will give us the final incentive payment. And this process is going to happen once per year. And also for year one, providers will not be responsible for any losses. You will only share a portion of the savings based on, all these factors I just mentioned earlier. Cindy, I see your hand raised. Do you have a question?
I do. I have a couple. So first one is in regards to the time period. Will it always be a 10/1 through 9/30 that these rates are set on?
It won't, Cindy. So we're still finalizing what period of delivery we're going to look at for year one, but preliminarily, we will use the first performance year's delivery. So so the actual cost will be based on the delivery happen 9/1/24 to August 31st, 2025. And then the target price will use the year prior. So 9/1/2023 to August 31st, 2024's episodes to come up with the target price. So the 10/1 period is just for, based on all the amount required for our dry run purpose, we use that period of delivery, but in after program go live, it won't.
Okay. My second question is, you had mentioned about inpatient costs, and you're saying you were going to remove them out?
So
take them out of the actual cost?
Sorry, and maybe I wasn't clear. We absolutely do not want to remove inpatient costs. We reprice them, right? Because
Reprice them, okay.
yeah, so we want to, because, for different providers or hospital have different pricing factors for the same procedure. We want to take that variable out of this exercise. So we basically come up with a sort of a standardized price for each type of DRG and severity. And then instead of using the actual reimbursement amount on the claims, we replace that with what we think the standardized price would be. And that is done for the inpatient hospital cost.
And you are only looking at these maternity costs. So if a woman is in a car, pregnant, gets into a car accident and goes to the hospital, those won't be included in the actual costs, correct?
Yes.
Okay, great. Thank you.
No problem. Any other questions? Okay. Moving on. Yeah, so this is sort of just I guess a glance at the format of the report we've shared, right? So you have your specific provider name and billing tax ID included in there. And then on the bottom of the table, we just outline all those, key factors, including the attributed episodes for your provider 10, based on the period of episodes that we just mentioned earlier. And then again, the target price, actual episode cost, net savings, and then the provider share, final quality score, and then the final incentive payment. So those should all be listed on your report. But I do want to note, those calculations are all based on historical experience, which means they are reimbursed fee for service. And then they follow a standard, traditional billing practice. In year one, things will probably different. So, it should not be, indication of what your year one incentive payment look like. It just directionally, we want to, or we want to indicate how this calculation works step by step. Okay, next slide, please. So this is the second component, or I should say this part of details is also including your historic performance results. This is to outline all the quality measures, right? So we have 5 pay-for-performance quality measures, and we have 5 pay-for-reporting quality measures. So, and also you can see their metric weight. That is basically how we assign the weight, and then so that we can combine them all together into one final results. A reminder how we calculated the pay-for-performance pay-for-performance measure is by looking at each provider's performance during the performance year, against the range of peers' performance for the same measure in the prior year. So, for example, for cesarean birth, if provider A has the cesarean birth rate of 30%, and then in the prior year, we noticed a range of 20 to 40% of cesarean birth rate among all the providers, then that 30% of current year performance is a 50th percentile of last year's range among all the peers. So for that measure, you will get a 50% as the quality measure results. And the same exercise happens for all the other measures as well. And then we will weigh them all together by the metric weight to come up with one result. And that is the performance tier score. And also, we also shared the improvement tier score. That is only we're only gonna use the pay-for performance metric with the same kind of evaluation system, but then we look at the year-over-year comparison for each provider, and then we combine them all together to get to the improvement tier score. And then the final step to calculate the percent shared savings, that will be the max of these two performance tier score, and then the improvement tier score. Whichever is larger will be your final percentage of shared saving awarded. Right now, as during our dry run period, the last three of pay for reporting measures weren't available. So we just use sort of a placeholder to indicate those potential results. But, obviously after year one, we will be collecting all of these measures and then incorporate their results into the actual calculation. So Cindy, again, I see your hand raised.
Did we get this report with our historic? Because I know I saw the report prior. I don't recall seeing this specific report with our historical data. Was that provided?
Tiffany, please correct me, but I think we did.
I think, yeah, I think these were all provided in one document for the historic performance report.
Just confirming, I think we have a few folks from our provider relations team who I think we're helping also communicate.
You're saying yes, they got it. Everyone got it. I need to search where ours is. Okay.
Please let us know if you don't. We would be happy to hear from you, and if there's issues with it, we want you to make sure you do it.
Thank you.
Then Cindy, we can send that to you.
Thank you very much.
No problem. And totally understand. We know there's a lot of documentation. This is a new program. There's a lot of information. And so definitely want to take the time to make sure that you are able to understand it and make sense, and you can ask questions. So please let us know if you have questions or if you don't have it.
And I received another question chatted to me. So is the historic performance results reconciliation and incentive payment at the provider or at the TIN level? And this is all happening at the TIN level.
All right. If there's no other question about historic performance reports, Brad, I think I'll hand it over to you for some case tree updates. Thank you.
Great. Thank you. So just a few things we're going to touch on now includes a few items we've heard from, and I just also wanted to flag, we had some additional questions come in and comments that we're planning some other internal follow-up on, but we wanted to make sure we touched on these three items that we touched on in the last forum as well here. So that includes maternal fetal medicine, inclusion, case rate reconciliation, and dual services. So we'll be jumping into those three here. And so on the MFM inclusion, we can go to the next slide. And we've been hearing some concerns about including MFM providers, and we did carefully both consider this early on, and we have re-looked at this again, and we just as our recommendation or our plan is to maintain MFM, continuing to include MFM providers in the maternity bundle for year one. And some of the rationale for this is previously, when we were making this decision earlier on, including as we were talking through this with the advisory council, which obviously things change and evolve over time, but some of this is make sure we're including members that are at highest risk. We do think that this program over time will have, we think, significant positive impact on the type of care that can be provided as providers are able to evolve practice models to fit this. And we'll be encouraged to provide more holistic care. Not that they aren't trying to already. We know providers are trying to do that. But hopefully this payment model will encourage that and incentivize that in a way that there's win-wins across the board, including for our members who need the most care, are highest risk, and need either MFM collaboration or primary maternal fetal medicine care. So that's the highlight. And I also did want to highlight some of the concern. I know that one of the worries was that the complexity wouldn't be accounted for in terms of the case rate. And how the case rate is built, it is utilizing historical performance, including payment. So if there are higher need members that are being seen by MFM providers, that is accounted for in the case rate development and including the case rate itself. And so I just wanted to make sure to highlight that. So in terms of provider implications, so for in-house MFM for services, those provided within the tax ID, they'll be reimbursed by the case rate. So that's what that means. In terms of external MFM services, so if they're provided by a participating maternal bundle provider, for example, but they use a different tax ID. So there's a co-management, for example, model, but both have a case rate. Both providers can receive a case rate as long as they're billing a correct CPT code along with the diagnosis code that will trigger the case rate on a recurring basis. So both can be paid in the same month at the end of the month. So just to say, we have built the model in such a way to allow for that. If a MFM provider is not a eligible maternity bundle provider, say their TIN is not included, they will receive fee-for-service payments. And I see there's a hand raised, so I'll get to that in just a second. But again, both can receive case rates at the same time, as long as they're initiating those case rate payments on a monthly basis. So let me pause. I see a hand raised, Joshua Kopel.
As an MFM, we share our TIN with a number of low-risk practices because we're a distinct practice within Yale of high-risk obstetrics. So if we share a TIN, how are you going to know the case rate for MFM versus the case rate for the specialty obstetrics? We may be part of obstetrics, but we're a subspecialty with a different taxonomy code if you had agreed to use taxonomy codes as the way of classifying the patients.
So from the payer standpoint, what gets reimbursed, and so we wouldn't distinguish between at the TIN level. Those are the MFM providers. Other providers would be included in terms of accounting for all of the billing that goes underneath the TIN. So it does get put together on a whole. The TIN, the goal is to make the TIN whole in terms of the case rate. So including for MFM providers. And obviously this comes back to how a little bit in terms of how the accounting is done at the, within the Yale system that as you're talking about, which may require some adjustments in terms of how that's looked at, because the case rate, again, is accounting for all of that for non-MFM and MFM providers within it. So I understand that the concern in terms of, I think what you're probably raising is that on a per case basis, the MFM provider, when they initiate a case rate, it may seem, I would imagine, lower than it would be to the other provider, because the case rate, again, is being blended across the entire TIN. But again, the TIN reimbursement will be made whole at a large in terms of that internal income, or revenue that will be brought in.
That just makes no sense for the kind of practice we have, because we have private practices under our TIN that are taking care exclusively of low-risk patients.
Sure.
And that means their reimbursement will be inflated because they're getting averaged together with our patients. And our patients will get less because we're being mixed in with the low-risk patients, even though we're taking care of the most complex patients.
Yeah, I don't know how, I think this does come back to accounting a little bit. This could be accounted for depending on how things are done at the TIN level in terms of, and I know this gets complicated because it does have to do with internal accounting practices for how that's accounted for. So I definitely understand that is not that is challenging. We didn't have the capability of doing at a smaller breakdown than at the tin level in terms of our capability. As we were looking at it, it really made sense to do this at the tin level.
You couldn't add taxonomy codes.
You mean taxonomy for provider type? Is that what you're saying?
Yeah.
We actually have been looking at some of that ability. You mean paying at that level? Is that what you're asking for?
Well, you can distinguish a specialty obstetrician from an MFM by the taxonomy code that's attached to the bill.
Indeed, there is capability of identifying it. The challenge is paying at various levels in terms of how we do the reimbursement for this. And there, at least as of now, we have set this at the tin level. I do want to say that there's opportunity to continue, I think, ongoing discussion, but really for year one, that's not something that is at this point, we're very far along in terms of how this has been set. Understanding there are challenges that specific provider organizations may have based on how that tin is set. So I hear you, the tin is very broad. It includes a ton of, what you're saying, a lot of provider types. I think that is something that, again, internally as a whole, the tin will be made whole in terms of that case rate, but I hear the concern that you're raising in terms of that variability at the specific practice level within the tin. And happy to have a follow-up conversation. Would say we had a meeting a few weeks ago. Tiffany, correct me exactly when, with some of the Yale population health team, and I just invite that we'd be happy to have a follow-up conversation and make sure that you're included and others are included in that conversation.
Thanks. I think it would be helpful to have the clinicians included, but Cindy and I can talk about that offline.
No problem. And I just want to say we do want to have those conversations, and I know this is a new program. We know there's challenges with both understanding how it's working and also how it's going to impact practice at the various practice levels. And so we are interested in meeting with providers and continuing to have those conversations as we look to roll this out, both for feedback. We anticipate, obviously we're getting relatively close to launch. There's very limited things we'll be able to do prior to that, but there are, this is a program that we anticipate continuing to evolve over time and try to make to improve so that it works for providers. Now, some of this may work for different how things are set up at one provider group versus others better, but we're looking to hear from you all and wanting to understand some of those challenges. And if there are things, whether that's we can do actively or in the future, we definitely want to hear that. And I just want to acknowledge, we definitely have been trying to listen in terms of the concerns, especially around maternal fetal medicine providers. And I think specifically about the practice that you're describing in terms of that being set up, maybe unique to other practices in Connecticut. I see Cindy, your hand is up as well.
Could you confirm that the MFM deliveries were included in the draft case rate? Because what concerned me was our case rate was below the state average, and we found that very concerning, seeing the majority of our Medicaid patients are delivering through MFM.
That should be the case. Grace, do you want to chime in?
Yeah, we did not exclude any type of professional services from the case rate calculations. Indeed, we can go back and double check, but I don't believe we exclude any type of professional services based on the provider type. So basically, the case rate, the how we came up with it is like after attribute cases or episodes to providers, we just looked at all of their professional services covered by the zero pay code list. I think you can also find on the website. So if there's a MFM bill, a professional delivery service claim, as long as the codes are included as a zero pay part of the zero pay code list on the zero pay code list, that service cost will be included in the case rate.
What happens with global billing? Are you able to capture it via if we're doing global billing?
Yes, global code is one of the zero pay code. So any costs associated claims are included.
Okay. Yeah, I was
I
just
think-
concerned about, that we were below the state average. That, was a head scratcher.
And we had, when we met with the team previously, we had actually, asked if there was additional, some information that would be helpful for you all to see in terms of the case rate information as much as we reasonably can provide. We're interested in figuring that out. And I think they were going to get back to us
Okay.
in terms of what might be helpful. And again, we want people to be comfortable and understand that that's part of this process. And so we're wanting to engage. So it sounds like a follow-up meeting would be
Yeah,
helpful.
It
and
sounds great. Yeah.
I'm happy to
And
do
any
that.
data that we could have probably to bump it up to see if we tie out would be great. Okay. Thank you so much.
Yeah.
No problem.
One thing I just want to add, Cindy, I think it's probably not a concern, but we did also have, so the claims will be included in the case rate are the ones obviously on the the zero pay code list, but also the billing provider type will have to be, I think, one of the 6, like maternal care professional. So I don't know if, I think we might have shared those 6 codes as well, but those are just the only 2 requirements. Just want to note that.
So I think maybe, go ahead, Christine, I see your hand was up.
Thank you. I just had a quick question. I want to make sure I'm understanding this, so thank you. And from UConn Health, so it would be the University Physicians is our provider group. So we also have maternal fetal medicine billing under the same tax ID. So am I understanding this correctly? So we would fall in the in-house MFM services category, correct? This first bullet under provider implications. And we'd be reimbursed the case rate. The MFM would be reimbursed the case rate. But if this in the second bullet it's saying external MFM, the maternal fetal medicine and the OB practice both get the case rate. So why wouldn't we also qualify for both case rates?
It's because of how the case rate is set up. So this is, if it's under the same TIN, we've included all of the, under the tax ID, we've included all of the billing to date in terms of utilization and claims data underneath that to set the case rate. So that's set, and we've set it to at a monthly case rate starting the second trimester. For providers that fit under a different TIN, each tax ID has their own case rate. And so what happens is we're taking those historical patterns of practice. So if you're practicing already and you have an MFM provider that's doing co-management internally, that's accounted for in the case rate. If you have, and it's similarly accounted for if you have a external TIN, say there's a separate MFM practice that's in the community that has their own, that does deliveries and has their own case rate, and there's a independent OB practice that's not an MFM practice or a certified nurse midwife practice, for example, they each will have their own case rate that accounts for their historical billing patterns. And so that case, we want to make sure we're reimbursing providers underneath that existing historical framework. So for example, if there's a co-management model, and say this is the certified nurse midwife practice and the MFM practice, and they're both seeing the providers monthly, they both can get individual case rates. We've accounted for that utilization and billing practice in that historical capacity in each of those case rates. Again, we've set them at the 10 level. And so that's the reason why, is because we'd be overpaying that. If we made 2 payments for the same tax ID in a month, that would be an overpayment compared to how it's structured. Grace, do you want to add anything to that?
Sorry, I was trying to come off mute. Yeah, so what Dr. Richards, I think what you said was accurate. But basically I think the wording might be a little bit misleading, but when it's in-house, it's all about what TIN you belong to. Like Dr. Richards was saying, if you belong to a TIN that's already have this case attributed to, well, that's business per usual. So you just get the case rate. But if there is an MFM taking care of the same member, but they belong to a different TIN, just like any other provider under that TIN, they will, if they build a trigger code, that case will be attributed to the new TIN. So yeah, so it's really it's really just like MFM versus not MFM. It doesn't change anything. It's just like which TIN built a trigger. That's the key factor there.
And the case rates are set accordingly, correct? So if
Yes.
there's more volume, right? So is it safe to say, or am I understanding it correctly, that an in-house MFM services potentially or should get a higher case rate, correct? And the combined external MFM and OB practice, the combination of those two would be would equal what the in-house MFM is getting, right? Based on utilization and historical claims, correct?
It just depends on it would depend. It wouldn't necessarily add them up because it's based on historical patterns of utilization. So, for example, it could be different if one MFM practice is purely consultative and doesn't do deliveries, for example. That would look very different than an MFM practice that does deliveries as well, and that's going to be accounted for in the case rate. Grace, anything you want to add?
Nope, that's accurate.
Okay, so it's based on utilization, correct? It gets set at utilization, set accordingly according to utilization and volume and historical. Okay.
Yeah,
Thank
and
you. Appreciate
Oh, sorry, Chris.
Yeah, so not just utilization, but also like historical costs, right? So if you're the same volume utilization, but one MFM has been performing higher cost sort of type of services, then, you know, obviously whatever TIN that MFM belong to will have a higher case rate than the MFM who only perform sort of like a lower cost or lower reimbursement rate services, even though they have the same volume. I just want to make sure when we talk about case rate, it's like utilization, unit costs, all those are going to be factored in.
And I'll just say, and the goal as we were setting this is really to as part of the case rate set is to make sure providers are made whole. And actually, we'll get to it in a minute, but we'll be saying that as part of the case where we actually anticipate additional dollars going to providers, which I think is on the next slide. But Mark, I mean, your question may pertain to this one specifically. So maybe before we get there, we'll turn to you.
Thanks. I'll try to make this quick. So in the scenario where there is an OB and an MFM who's co-managing, you're saying they both may bill a trigger code that qualifies for case rate payment, and that's regardless as to who gets tagged with accountability from an episode price and quality perspective.
Say that in terms of the accountability component.
Yeah.
It depends on who's typically accountable. So there does have to do like, are you taking on accountability are you planning on taking accountability for this member or not? And I know sometimes there's some uncertainty potentially in some of these cases. So, but there are going to be occasions when a MFM provider is only planning and knowing that they're going to provide consultative care. The case rate is built around the attribution logic where we're attributing pregnant individuals to the practice. And so if you're in the case where a MFM provider, even post-launch, is only providing consultative care, they are able to not bill a trigger event, and that would not switch to a case rate. We wouldn't get reimbursed fee for service, if that makes sense, Mark. So it doesn't, there's still capacity for purely consultative care without the plan to cause attribution, especially if that's the existing practice, the existing model of practice.
Thank you.
And before we move on, there were two other questions that came through to me in the chat. First one, we might be getting to this in the next slide, but is regarding how do you ensure organizations are going to be made whole through the case rate payment? Brad, if you want to speak to that, or if we want to wait.
Well, maybe we go to the next slide, unless the other one pertains to MFM, and then we'll get to, is that?
The other one doesn't pertain to MFM. We'll hold that question. The other question that came through is, have we released the risk adjustment factors yet? I don't believe we have as of this moment, but there is additional information at a high level in the program specifications on DSS website.
Yes. And maybe we can briefly come back to that at the end, and Grace, you could give a very high level overview as to that. But just in terms of pertaining to how the case rate, and I know there was a request that we heard about doing case rate reconciliation back to fee for service because of the concern that there might be negative practice revenue, which we understand anytime there's a new program, there's going to be concern about the effect on revenue and being able to pay staff, et cetera. So we definitely understand that. However, I'll first to say we're not planning on doing that. And let me explain why. And let me go to the last bullet under provider implications. So as part of this in development, we anticipate that there's actually opportunities for additional revenue through the case rate payment. And this was our Mercer team helped develop the case rates. These case rates have to do with how frequently services are being provided over a member month basis. And so we know that historically not all 9 case rates would have been made. And so the case rate, that goes into the assumption of the number of case rate payments that are made, which creates an opportunity for providers to provide earlier care in the second trimester that actually can lead to that would lead to more reimbursement over time. And so our internal assessment is that there'll be additional $4.5 million in state year fiscal 25, 6.2 and 26, and 6.3 and 27. And so my own personal worry and our worry, as we discussed, is if we reconcile back to fee for service, there's actually I would say a decent probability that providers could actually make less money than they would under this based on our internal assessments, because based on this case rate, while we're not putting new dollars in, there's actually opportunity to bill to initiate the case rate earlier than providers may be able to at the moment, and actually generate more revenue than they currently are in the existing fee for service model. So that is partially rationale. The other is that really we're trying to have providers being able to think more holistically about the care that's being provided. And fee for service obviously is really for having folks focus, including somewhat through the global code, which has very specific requirements in terms of what services are being delivered, thinking more holistically about the care that's being delivered as part of this program. And obviously that will take time to take hold, but doing a fee for service reconciliation would, in the long run, I think, really have people continue to focus just on making sure they're meeting their fee for service revenue versus saying we're able to generate a monthly case rate, and we're also focusing on outcomes that we think will drive improvements for maternal members. So I see, Cindy, your hand came up and wanted to make sure we got to you.
Just to dummy it down for me. So if a patient comes in, a pregnant woman comes in at week 14 and a trigger code is sent and the case rate starts, will she need to come in the following month and another trigger code sent to continue receiving the monthly case rate, or will it just automatically be sent regardless if the patient comes in or not until another carrier or another provider drops a trigger code, and then it'll switch over, automatically stop from one TIN and start with the next TIN?
Cindy, you got it. It will, once it's been initiated, it will continue unless there's another trigger code diagnosis that's been sent.
So if Betty doesn't come in, we'll still get the money for Betty that month.
That's correct. And we're hoping that this will encourage practices, and over time, we know that practice changes not happen overnight, but over time, we hope that this will encourage providers to be much more proactive in identifying their high-risk members and really saying, like, do you need an in-person visit, or actually is a phone visit completely acceptable, or a video visit, or whatever makes sense for the member in front of you? Because we know people's needs are different. And so hopefully this allows for a little bit more tailored approach based on risk and need over time.
Thank you.
Patricia, I see your hand up.
Hi, thank you. I don't know if I missed it, but is there a list of the trigger codes that we need to follow?
There is a list. It's on our website. We can probably put the link in the chat if that's helpful. Tiffany, does that work?
Perfect. Thank you so much.
No problem. And Mark, your hand's up as well.
Sure. So I want to focus on what is, at least this week, seems like new information, which is about something we've taken the position in previous comment letters at CHA that there should be some net new investment in the core maternal health services that are being provided, beyond doula and lactation consulting, if we're expecting providers to be able to do more. And so it looks like this is additional budgeted investment dollars in the setting of case rates, which folks probably heard about it on Tuesday, but I'm hearing about it now, appears to be significant. Can you give me a sense, or give us all a sense, what's the denominator here? So, and is the 4.5 because it's 10 of a 12-month year, 10 months of a 12-month year, or or the whole prospective thing of what do they call it? Slow down or speed up scenario. What's the basis for the difference, and what's the denominator? 6.2 million compared to a base of what?
I don't have the base off the top of my head. It's a good question, but I can say the 4.5 and 25 is because of the state fiscal year, because we're not launching till September. And then the change over time is, obviously 6.2 versus 6.3 isn't a drastic change. Some is just, we expect there'll be providers doing more early interventions because that's a way of generating, that's really truly a win-win. If you can get pregnant individuals earlier, we think that's probably better across the board. And I know that's something that people are interested in already, but the incentive will be there to do that as well as part of this, because you can start the case rate beginning early second trimester. So you can say, hey, we really want to see you then. We'll initiate the case rate, and that really can set providers off with an extra payment that they wouldn't otherwise gotten. The denominator question, I think, is a good one. I don't think we have anyone from fiscal on that can answer that right off the top of right off the bat.
If you could follow up on that, that'd be great. So that's different than I first understood. So what I'd understood was you basically calculated case rates based on historical performance, and to ensure that there is payment sufficiency across the board, there's some percentage increment in the case rates that would cost the state 6.2 or $6.3 million. But it sounds like it's more that you're projecting certain changes in visit and practice patterns that might result in more revenue, but that's proportionate to the additional resources expended by the practice. So it's not like it's a cushion or even an add so much as, because if a practice is seeing patients earlier, then they're dedicating resources they weren't dedicating earlier, which is a good thing, but that doesn't, but there's still, how can I say this? It doesn't mean it's new money that's not tied to a new resource. That's
sure, understood. It requires someone to see the member, engage with them. So understood that is possibly a change. I do think one thing that there may be mutual benefit or benefit for the member as well as the practice is that earlier engagement. There's decent data that early prenatal care may benefit some of the adverse events that can be seen in mitigation, and then thinking about the shared savings opportunities as well as and trying to meet some of those quality measures to increase shared savings. So I think you're right that there may be more intensity because you do need to see someone earlier than maybe you had planned on. With that said, there is additional flexibilities in terms of what that continuation of care may look like. So I think providers hopefully will have a little bit more understanding that there's practice change takes time, and we know that. So I hear what you're saying, Mark, and think yes, there is even though there's additional dollars, there may be some additional need for service in that time.
So just to provide feedback on that new information, if a practice was formerly on average seeing patients 10 visits and now they're doing 12 visits because they're getting patients earlier, they're also providing more billable services, right? They're going from 10 to 12 on average in billable services. So it seems to me a reconciliation, which would provide a certain reassurance that you're not going to be underpaid relative to your sort of visit efforts and other sort of practice-based diagnostics and services. It is, if in fact that projection is because you provided more billable services, but you're getting the case rate for it, it doesn't seem to me it's likely that it would result in a negative impact on the provider when you true up. Not that there's going to not be some ups and downs that are counterbalancing, but that on the whole, I don't think it leads us to rethink our recommendation that practices have the opportunity to do a reconciliation those first 2 years to
Well, just-
ensure that they're not frankly that practice revenue that's critical to providing services is not jeopardized.
The only thing else I'll point out that I think, Mark, it may be helpful is that case rate does include, inpatient delivery service utilization spread out. And so it would be surprising to me if that additional payment didn't more than cover that additional visit volume, given what E&M codes are reimbursed at. It would be a little surprising to me, but it's a good point. And, providers will have the flexibility of saying, well, you're seeing them earlier. Do you need to see them? Is there a time when you don't need to see them, or you change it to a less costly service or something that's, so I do want to say providers do have some flexibility in how they think about that delivery of service that should generate a little bit more revenue. Now, you're right. No, we don't know completely, but I do think that it would be a little surprising to me if, even if you did an additional one visit, that it wouldn't be more than compensated for in that case rate.
It's the we don't know. I think that is of most concern to us, and it's in running a practice that does maternal health, it takes more than a hope and a prayer to ensure that you're making ends meet and covering practice expenses that are necessary to ensure that patients are getting adequate service. So all that's.
And I'll just say, I think we definitely are interested if there's additional information in terms of making providers understand the case rate. We're interested in hearing. Again, I mentioned earlier, we did have a conversation with some of the Yale team a few weeks ago and asked if there was additional things that we could help provide. Obviously, there's some information we will or won't be able to provide. We do want to make people feel comfortable with the case rate, understand how it was developed. Truly, the goal is to make sure we're making providers whole. And I think we've done both we've kind of had two checks to look at what we anticipate that what will happen with the case rate and does appear there will be additional revenue generated going to practice, understanding some of the concerns you raised.
Thanks.
Patricia? You're on mute if you're trying to talk.
Sorry, I forgot to put it down.
No problem. And I know there was another question. I don't think it was pertaining directly to this. And maybe the last one, we'll go to the next slide and we'll then get to any other outstanding questions. The last one is on doula services. We also heard the concern about the complexity for providers and practices to have to monitor the additional revenue for those that are not sure how they're going to handle doulas. The position of DSS is that we do see doulas as an important part of the maternity bundle. And as those may remember, there's two options. We decided two options essentially for doula reimbursement. There will be a fee-for-service option that we'll be moving towards, and as well, there's an option for doula to work directly with providers as part of the payment. So, but we've heard the concern, and we're allowing for a doula opt-out for those who have not heard for that specific payment. So there's the case rate you've seen does not include the add-on payment. The add-on payment we had projected was $21 at whole. 14 of those dollars was for doulas, 7 for lactation support. This only pertains to the doula add-on. We're saying for the $14 that we had planned on adding, we will allow for providers to opt out of that. So if they do not want to receive that payment, that we will allow that we'll be working through a process to get that opt out, and we'll be CT provider engagement services. We'll be reaching out shortly later this week, should be happening. And then we'll look for a response by July 10th, just so that we can make plans for that. So that's, again, we are allowing for a doula opt-out. That will mean that providers will not receive the doula add-on dollars that are planned to be dispersed, with the goal of using those dollars to have providers directly supervise and work with doulas. This could, we haven't decided in terms of changing this for year 2, but imagine that this would be something we likely do on a yearly basis, but we'll try to confirm that later. So just wanted to make sure that folks, we tried to make sure we listened, we heard this, and that we thought this was reasonable. Understand, we really do want doulas to be a prime point of moving forward as part of service delivery through the DSS Medicaid maternity bundle program. So let me pause, see if there's any questions on this particular topic.
One question that came to me is asking, if we opt out of doula services, how will this impact our quality measure for pay for performance? Will the measure be reweighted? And just to clarify, I believe the doula measure is a pay for reporting measure.
Yeah, and so it won't have an impact. We're looking to capture the data and understand service utilization for doulas. I mean, one thing that I just want to make sure to flag is it's a pay for reporting just for data collection. And we will, for those who are participating, there will be we do anticipate collecting administrative data or data about utilization from providers so that we can do a doula true up and make providers whole for if there are doula services that are utilized through the bundle, or take those dollars back if we overpay for those services. So that is part of this process and plan moving forward. And all to say, we are interested in thinking about, do we have doula utilization as part of a performance score for providers? Do we move that from a pay for reporting to a pay for performance in the future? That is yet to be determined. That would be something that would need to be discussed extensively before doing. But I just want to flag there's interest in that, and there was interest in, I think, in those discussions previously with the advisory board. I think with that we can. Oh, Mark, please.
So thanks for that information about the option of a doula opt-out. So the lactation consultation is not an opt-out option. And previously you talked about some sort of reconciliation around services provided that were included in the case rate that may or may not be provided. So if I'm a practice and I did lactation consultation with this additional money, can you say something about whether you still intend to do a reconciliation to determine whether the level of lactation services provided matches what you paid or not?
As of now, there's not an anticipation of any reconciliation of the lactation support services. As you may recall, we had with the limited funding we received to include doula and lactation support services, we had to make a interim decision about where we would put the more significant funding, and we went with putting more towards doula coverage, understanding that lactation support is extremely important and not something that we want to shortchange. But we see this funding as something that we will ask providers to utilize in a way and meet the needs of the members in front of them, including screening and then counseling and referral, potentially to internal resources as available for lactation support, knowing that we will, without, as of now, any plan to do reconciliation on the lactation support dollars. All right, so just on doula, I already mentioned this, so I think we could probably, but there'll be 2 options. There'll be through the maternity bundle, and again, there'll be an opt-out for at the 10 level. And then we are working on rolling out a fee-for-service option for doulas, where doulas can directly enroll for those that have been certified through the DPH process. Just as note, the provider supervision. So if you are a provider that is accepting these dollars, the provider will be supervising the overall care plan. The medical provider holds professional admin responsibility. Doulas will use their own professional judgment, and doula will work to the full extent of their scope of practice, or can work to the full scope of practice. There is a very helpful resource that Primary Maternity Care, which contracted with DSS previously, had helped put together on our website, and maybe we can link to that Tiffany, in the chat, just for those who haven't seen it, including thinking about how doulas and providers can work together, and some additional resources. Anything else, Tiffany, you want to flag on that?
Yep, no, I would just add some of the resources are there for practices to use and to customize if you choose to use that and accept doula dollars. So I will link that in the chat.
Great. I think we can just, and again, this is just on the add on. So that's the $14. Again, we will add up, opt out of that. And then there will be the retrospective true up, which I mentioned. We'll look to true up to true utilization of the doulas utilization underneath the bundle. We don't necessarily go into great detail here unless asked for, but again, we'll be making these payments. The total amount for doula that's eligible is $400 for visits. That's $100 per visit. That's up to 4 visits, and $800 for participation in delivery for the doula. We will true up to that amount plus a little administrative funding for providers who are opting in. And if there's any questions, feel free to ask them. I do want to just kind of mention a few next steps. Again, for the opt-out, will be our CHNC team will be reaching out to check in with providers who do want to do the opt-out. And we'll be finalizing our first year case rates by August 1st and sending those out to providers. The other resources are listed here. Thanks, Tiffany, for including that doula toolkit. Again, through our prior contractor, Primary Maternity Care, did a really, really great job of assessing the doula landscape, as well as providing resources for those providers who are interested in working with doulas directly. I'm going to have to, I'm actually going to hop off, but Tiffany will take over any additional questions at this time. And just I'll just say thank you all for participating, and we're really excited about launching, and we look forward to continuing to engage with you in this process. I just wanted to also flag, this is my final week as the Chief Medical Officer at DSS. I will be remaining and working on the maternity bundle moving forward for DSS, but in a more part-time capacity. For those of you, feel free to continue to ping me about specific maternity bundle issues. We'll continue the work, and I'll look forward to continuing the conversations. Thanks, Tiffany.
Great, thanks, Brad. I will go ahead and raise one question that came through in the chat. What happens when a patient starts with one practice under one TIN, then transfers care to another provider or practice under a different TIN? Does this first practice get a case rate for the first time they had the patient? So the answer to this would be yes, with the caveat, if the first practice has triggered the case rate payment, they will definitely get the case rate payment for the time they had the patient. I will note the case rate payments only start from the second trimester onward. So if a practice saw the patient in the first trimester, that would be paid fee for service. And then once it goes to the different provider or practice under a different TIN, and that TIN provides bills a claim with trigger code criteria, that practice would begin receiving the case rate going forward.
Thanks, Tiffany. I just want to add one thing, is that the original provider, as Tiffany laid out the scenario. So let's say on the 4th month of pregnancy, provider A had the trigger, and then they had the case, right? And then they get a case rate for the 4th month of pregnancy. But on the 5th month, let's say somebody else, a different TIN, got this case by billing a trigger code. So for the 5th month, obviously provider B will get the case rate. However, for provider A, who was initially the attributed provider, they can still get that month of case rate for the 5th month, as long as they've billed a zero pay claim. So, for the 2nd month, it will still remain having the case rate if they've billed a zero pay code claim. But for the following month, they will not. They will go back to fee for service unless they bill a trigger code on this during the 6 months. So there is definitely opportunities where within the same month, multiple provider could be receiving case rate. Just want to note that.
Great, thank you. Another question came through. Could we provide more of an explanation for place of service 11 as part of the trigger code criteria?
Yep, so that's the office visit. So so currently we've been, so the trigger code has, so the one episode start to be attributed to a provider. The provider has to meet certain requirement, obviously. So that has to have that trigger code where Tiffany, I think, has shared in the chat where you can find those codes. And on the same claim, it has to have a E&M code. Also, it has to be, the claim has to have the place of service there as 11, so that's office setting. So if a trigger claim is billed, but this service happens somewhere else, as of right now, that claim will not trigger a case, an attribution. I think we're still in the evaluation to see if we want to expand that place of service to some other settings, but as of right now, place of service equals 11 is one of the requirement to have the trigger event starts. But obviously that requirement is not there for any kind of zero pay code, to zero out any kind of claims to be covered by case rate. So that place of service requirement is not needed for any, future actions.
Joshua, I see your hand up if you want to unmute.
So can you clarify if our place of service is outpatient hospital, not office? Where all our claims go in that way, none of them are going to trigger participation in this program?
Joshua, I think right now that's the, original plan. We're evaluating to expand it to like 19 and 22. So there's a potential where out in the outpatient professional service or whatever that 19 or 22 setting is, we might also consider them to be able to trigger a case rate, but that is not finalized. We just want to.
So September, when this program starts, our practice that I've been giving you all so much grief about, and I know I'm like a broken record about the problems we've got at Yale, and maybe this is going to apply to UConn too. Everything we do is outpatient hospital. So we actually won't be under this program, if I'm understanding you correctly, unless you make some change down the road to include outpatient hospital place of service.
That's if that is the only place of service where a trigger code is going to be billed, then yes.
Well, there would be the inpatient hospital services. I don't know. I mean, the delivery itself is inpatient hospital, so I don't know if that triggers anything, but if
Is this place of service thing brand new? Did this just come to light?
It was definitely after we shared the draft case rate, Cindy.
Okay.
So the draft
Yeah,
case
so I don't think Mark was very kind to let me know something about case rate 22 and if it was excluded, would it help? Would it like change the impact? But there was no mention that this was only going to affect place of service 11. So, so I'm with Josh. I mean, we've been concerned, and now we need to relook at all our internal analytics to see if it changes stuff for us. Can you provide documentation that states that it's just place of service 11? That will
we'd like it
trigger
in
the,
writing.
yeah, like on your letterhead. So we,
Oh, sorry, go ahead.
no, just because this is new. I mean, I think from coming out of these forums, unless again, I overlooked it,
Yeah, we will definitely share documentation. I can share the program FAQ where we've listed the criteria for triggering a case rate. And we are planning to make a decision on the place of service, whether to expand that to 19 and 22 by end of next week. So we can also provide that announcement and make that very clear going forward.
What is going to influence that decision? How can we be part as stakeholders? Because I don't think we've been engaged as stakeholders, honestly. How can we be engaged in this decision as stakeholders?
Tiffany, I don't know if we plan to have like a, some kind of document collected to see the to have stakeholders more engaged. But internally, we are evaluating it by the fact to see if those place of service 19 and 22 do usually have the services that, like conceptually have prenatal maternal services. So I guess that's something we are still taking a look at. But if you have I suppose, Joshua, if you have opinions, we can probably collect them through some channel. Tiffany,
As a taxpayer, as a participant, as a stakeholder, I'd like to see the source documents that are being used to make this decision.
As background, I can say that I think where this came up is we wanted to make sure that I know there's some hospitals with labor and delivery triage where OBs might be working in the ED. And so wanting to make sure that we are appropriately attributing cases to just kind of the OBs intended for this program, not necessarily for emergency department triage events. And so that's kind of a little bit of background on this. Like I said, I'm happy to provide some of the documentation we have on this. And we can also discuss this additionally offline as well.
Well, I think it would be good to regroup with people that are interested before final decisions made.
Yeah, my understanding, I know Christine's got her hand up, is that you've already taken a position and communicated to at least one health system that you were excluding POS 22. So that's what I understood was an assurance that was given. So it does sound like you're considering walking back something that was communicated in the individual meetings. Anyway,
I can certainly take that back. This came up as a question in the last provider forum, so I think that's kind of why we are re-reviewing the policy. But we will certainly make sure that this is better communicated.
Yeah, because we weren't in the last forum, so we wouldn't have heard about it.
Understandable.
And my question was along those same lines. I would just ask, so the historic dry run performance reports are based on just place of service 22, place of service 11 then, correct?
Christine, what do you mean by the dry run performance report? Which one, which set of information?
So we received a report on June 14th from David Miller. This is specific to just our practice. And so he attached copies of the historic dry run performance report. So which identified the global case rate. So if the global, I guess my question is the global case rate based on place of service 11? Or is it all services and just the trigger code is going to drive?
So the global, so the case rate, the dry run case rate include all professional services under zero pay code. So the place of service does not play a big factor into the case rate. It will impact. Okay. Yes. So after.
Okay. Sorry. So what you're saying is, so just going forward, right? So historically, it was all services, regardless of place of service. And if I'm understanding it correct, if I'm understanding it correctly, the trigger code is going to be driven by claims billed in place of service 11 currently, and potentially 19 and 22.
Yes, that will impact.
Okay.
Yeah, I think that will impact the performance year case rate potentially based on our logic. But I think the biggest really, so for whether we include, so like the ongoing payment, whether it's fee for service or case rate, when it get triggered, the place of service will probably place a big impact on it.
Yes. Okay. Okay. Thank you.
Yeah, no problem.
Any other questions we might be able to answer? Okay, hearing none, we can probably end the meeting. And if you would like to set up an individual meeting with DSS, I'll go ahead and put my email in the chat just so we can go ahead and coordinate and set that up. Again, just wanted to say thank you. We really appreciate a lot of the feedback that we've received. And we want to make sure we're being able to answer your questions and be transparent in the information we're providing. So if there's data requests that would be helpful for practices to see, we will certainly take that back. Additionally, that same also goes for the place of service discussion. We'll want to make sure that we're making providers aware and engaged with what's happening on that front.